Good morning, everyone, and thank you, Mr. Clark, for your introduction and brief on today's exercise. Um, Today, I'll basically discuss the role of the Guyana Forensic Science Laboratory within the early warning system in Guyana. Let me share my screen. All right. Um, so I'll just slip past the introduction here. Mr. Clark did a pretty good job. um, Just a little history on the Guyana Forensic Science Laboratory. We would have been officially commissioned on the 14th of July 2014, and we had just about four departments um, where we were looking basically at toxicology, chemistry, trace evidence, and documents. But over the years, we have expanded to include three other departments, which is the video evidence, biology, and the ballistics unit. We subsequently gained accreditation in 2021 through the ISO 17025, accredited by JANAC. As I mentioned, we have about 14 departments, administrative, technical, and also involved with security in the operation. But our main focus today would be on the chemistry and toxicology department that supports the early warning system. Now, we've checked for a number of narcotics since we would have officially started receiving evidence in 2017. We would have processed a total of 60,497 narcotics samples. 80% of which yield positive results for various narcotics. Our main function within the early warning system is to detect and to report any new psychoactive substances that are seen. We use two type of testing. We do a preliminary screen using traditional thin layer chromatography, color tests, and other field drug test kits that are available. And we also conform using the GCMS, HPLC, and LC-MS techniques. In terms of reporting of our immune active substances, we often report, once we detect the presence of a new substance, we would provide a preliminary report on that based on the chromatogram on the MS library. And we provide a preliminary report to our clients. Thereafter, we try to obtain the reference material to confirm that substance or the presence of that substance. Because of the challenges in terms of having readily available reference material, we often would try to yield support from various sources in order to assist us. Some of the equipment, as I mentioned earlier, we have the GCMS, which we have staff that are trained to identify and also be able to report on their findings with regards to these new substances that we see emerging. Most of our training are conducted by the manufacturers who have well-trained experts also on board. Additionally, we would garner training from other universities or other companies that provide training in the use of this equipment also in order to boost our capacity at the laboratory. We also have the LCMS and the recently purchased Orbitrap. There's also preliminary drug screening test kits that um, we have procured and have been using for preliminary screening. One such is the narcotrace, which is very um, easy to use because of the sample types. You can use saliva, sweat, or surface along with the powdered form of the substances. We also have the scanning electron microscope, which we are exploring as an alternative approach for detecting um, seized drugs. Mostly it's analyzing crystal structures and the purity of these illegal substances. This is one of the work in progress that we're currently trying to develop and explore the options with regards to this equipment. Now, in terms of the new and emerging drug challenges, we've had a two, one of which is the detection and identification. And this is mainly due to lack in research in the area of modern technology used, especially in the Caribbean region. We found that the um, research support. However, um, with time, I know this will change performing these forms. You would have initiated a training and a collaboration recently with the DEA in the US. Would have exposed us to um, some new technology and also some new approaches with regards to research. And also, they provide source materials where we can also support the initiative of research in Guyana. There's also lack of access to um, reference material, or limited access. I shouldn't say lack, but limited access of reference material. However, we've been engaging with the UNODC and other development partner to remedy this challenge. One of the things we recommend is to have develop scientific collaboration and research initiative throughout the region, both regional and international. Secondly, we have trends in drug potency. While some laboratories may have the capacity to analyze the composition of these new psychotropic substances, there is a lack of, as I mentioned, toxicological research and training to monitor the trends and potency in the region. And also in Guyana, we recognize. So we feel with training and sensitization, this will no longer be a challenge. And one of the things we need to do is to have more collaboration, laboratory access to research and scientific groups to provide that continuous training and sensitization that is needed. Also, in terms of toxicological overdose and poison cases, most of these cases you see would come the emergency units at the hospital. And one of the things we find is that disconnect with regards to the emergency room and the data that is being collected and the laboratory performing the analysis. So what we find is that we need to, or we recommend is that we need to develop a framework that allows for timely preliminary results and also confirmatory testing. This will only be possible through interagency support and MOUs between all stakeholders that are that plays a role within the um, early warning structure or system. I think our um, Guyana Drug Information Network can coordinate these, which I've seen that we have initiated such, and it has been fruitful and showing some progress since the launching of the early warning system in Guyana. Now, for future support in terms of the early warning system and new psychoactive substances, we find that we need to be on top of it in the sense that we need to have timely results. And in order to have timely results, you need to have equipment that can both show some be efficient and also show accuracy in the reporting of all compounds or all chemicals or elements that are found within a particular um, drug. The concentration of the adulterant, the thinners, the acid drug, and to be able to better assess those toxicological effects that can emanate from those drugs. We also, in terms of confirmation, we also plan to have the NMR, which is a bit versatile in terms of determining the purity of all substance um, within a particular compound or drug or substance. And also the results um, can be garnered in a fast, uh, quick, in less than 24 hours. You have results available. And with that, we'll be able to better monitor um, persons who overdose. We'll be able to possibly treat them in a timely manner to avoid death. That's one. And two, also, we'll be able to send out early warnings to the population in terms of these new substances and the harmful effects that they can have on the human body. We have been working with the Drug Information Network in Guyana, and we have um, supported the initiative of providing results um, within the early warning system. We have sent out, I think a couple of early warnings were sent out recently. Um, Mr. Richards will speak on that aspect of it, but just a brief note from the laboratory aspect, we would have supported that initiative. I spoke about collaboration as one of the um, remedy or recommendations for our challenges, and we would have participated in more recently in a number of exchange programs that would help the laboratory build capacity in terms of determining the presence of new psychoactive substances. And also, you were exposed to equipment and technology used in the modern day analysis of drugs, and also having a bit of insight on research in that area. So, with time and collaboration, you will be able to remedy most of those challenges that we encounter currently with the support of all stakeholders, including the Guyana Drug Information Network. Thank you.
Thank you very much, Mr. France, for your presentation. I have a couple questions for you, but we'll save them for the Q&A segment. Thank you for sticking to the time and for your succinct presentation. Interesting stuff.
Yes, thank you, Mr. Thank you, Mr. Clark.
You mentioned
Thank you,
the
Mr. Clark.
go ahead.
Yes, I left a few things out so that we can have a discussion in the question and answer segment.
Okay. All right, thanks. Yeah, you mentioned the NMR, nuclear magnetic resonance spectroscopy, if I can get the word out.
Spectroscopy.
Yeah, that seems to be the current the in thing now, where laboratory confirmation
Yes, because
is
it's
concerned.
fast, it's versatile, and it actually helps you to see every single compound that is present in any sample and the concentration by percent.
At the molecular level, right?
Yes.
All right.
Yes.
Thank you
At the
very much for
molecular,
that.
you can identify everything that is there in
Brilliant.
any given
Brilliant. All right.
compound.
Okay. Thank you very much, Delon. All right. So we will move on very smartly to Mrs. Tracy Ann Bennett, Director of Chemistry, the Chemistry Department at the Institute of Forensic Science and Legal Medicine in Jamaica. Tracy Ann, you have the floor.
Good morning, everyone. Is everyone hearing me?
Yes, you're loud and clear.
Okay, good. Let me share my presentation. Okay, good.
Good to go.
Thank you. Thank you, Mr. Clark, for the introduction. So I'm representing Jamaica and the Institute of Forensic Science and Legal Medicine and our role in supporting the EWS in Jamaica. So just wanted to share a picture of our lab. That's our lab, an aerial view. And then to tell you a little bit about the Institute, just some background. We're the only forensic lab in Jamaica. We're the only forensic lab in Jamaica. And our primary responsibility are to examine and analyze physical evidence, to produce forensic reports and certificates, to provide expert witness testimony as required, and also to provide consultation and training to our stakeholders. We have 4 technical departments: chemistry department, the biology department that deals with DNA and serology, we have the ballistics department, and we also have the pathology department. The chemistry department detects and identifies substances in seized materials and biological samples, identifies adulterants and diluents, and also determines the purity of seized materials. And this is the arm of the institute that supports the functions of the early warning system. So in terms of the role of the laboratory, I'm going to go on to speak about toxicology for overdose and poison cases, the detection of new psychoactive substances, monitoring trends in drug potency and composition, and rapid information sharing and communication with the EWS. Detection of new psychoactive substances. How does the lab identify unknown or emerging substances in seized materials or biological samples? So first, the sample must be prepared, and this is dependent on the method or the test that is going to be used. For solids, tablets, we dissolve the solid in a suitable solvent and filter if needed. For our biological samples, we do liquid-liquid extraction, and we are seeking to add a solid phase extraction because we find from testing that we are getting better results with solid phase extraction. In terms of our analytical techniques, for seized drugs, we use the Raman, we use FTIR, GCMS, and LC-QTOF MS as needed. For biological samples, we use the Randox Evidence Investigator, the GCMS, and LC-QTOF MS. So I have a casework example where some blue tablets were seized in 2024, and those are the pictures of the blue tablets. The tablet has M on one side and 30 on the other side, and there were some tablet fragments as well. So we analyzed the tablets using Raman, and we found that there could possibly be MCPP and paracetamol. So we went on to GC. So on the GCMS, what we do is to use different solvents, methanol and chloroform mostly. We dissolve the tablets in both solvents, filter, run them on the instrument. From GC, paracetamol was confirmed, but there was also a small peak for fentanyl. If you notice with the chloroform extraction, the peak is a bit larger, and so we were able to search it. When we search it against the library of the instrument, we found fentanyl, but the match quality was only 50%, and that does not reach the threshold for identification. And therefore, we went on to the LC. So we placed the sample on the LC QTOF, and the result showed the presence of MDMA, fentanyl, and xylazine. And so those were reported along with paracetamol. What are the challenges with rapidly changing chemical structures? Mostly compound identification becomes more complex. For example, the catenones pentylone and utylone, they're structural isomers. They share the same chemical formula, but they have different arrangements of atoms. If you look at the structure, the difference between the two compounds is the position of a methyl group. It's just a shift in the position of the methyl group, so they are quite similar. When you look at the GC mass spec, the GC mass spec for both compounds, the one on the top is utylone and the one on the bottom, is pentylone. And they look pretty similar, and so it becomes difficult to differentiate between the two. So it becomes important to use analytical standards to obtain the correct retention time to assist with differentiating the two compounds. However, analytical standards are expensive, especially for NPS. They are available in very small quantities, and it takes a very long time for us to procure standards in Jamaica, about 3 to 4 months. Another challenge with rapidly changing structures is that this could mean that the new compounds may not be in the current instrument libraries that we have, so we would miss it. And entirely new methods may be needed in order to detect these new structures. In terms of monitoring trends in drug potency and composition, the Forensic Institute identifies the adulterants present for cocaine. It has been pretty consistent. We identify levamisole, phenacetin, and lidocaine. For methamphetamine, for MDMA rather, we've identified caffeine, ketamine, MDEA, methamphetamine, 3-CMC, and we've also identified PMK. We do not determine the potency of these substances, and we don't track. So we quantify cocaine, but we don't track the potencies. And that's the only compound that we do the potency for. Toxicology for overdose and poisoning cases. In order to determine that an overdose occurred, we would need quantitative data. Unfortunately, the Institute does not quantify how much of a substance is present. We do a qualitative determination. So we say that for example, cocaine is present. We don't say how much cocaine is present. We are currently working to have this done, and we hope that very soon we'll be quantifying or analyzing postmortem samples. For hospital cases, we do not receive those samples, so that's a blind spot currently in our EWS. Standardization and quality assurance. The use of validated methods and proficiency testing are very important in quality assurance because validated methods demonstrate that your methods are fit for purpose. And we do have validated methods at the Institute. Proficiency testing shows that our lab is providing accurate and reliable results. We do proficiency testing as well for both seized drugs and biological samples. We participate in collaborative testing services, proficiency tests, and we also participate in the UNODC ICE exercise twice per year for both seized materials and biological samples. When it comes to reference standards, we source our standards from Cayman Chemicals, Lipomed, and LGC standards. Those are one company now, Lipomed and LGC are now one company. Sigma Aldrich is another source, and we also obtain standards from the UNODC ICE program. Accreditation for us, we are still on the journey to accreditation. We recognize the importance of it, and so we're determined to get it done. We're still on the journey. In terms of sharing information with the EWS, this is done through WhatsApp and email. When it comes to alerts, the Jamaica EWS has not issued any alerts as yet. However, the IFSLIM stands ready to assist with developing alerts, bulletins, and risk assessments, performing risk assessments. Standardized reporting formats are needed to ensure timely and complete data collection and analysis. And so this is something that we would welcome. It would make the process much easier. Challenges and limitations. I mentioned this before, it takes us a long time to obtain our reference standards. They're expensive. Lack of equipment to routinely test for some substances. So for example, we have the LCQ-TOF. However, it is used for mainly post-mortem samples. So we do not wish to put a lot of seized materials on it because it's so sensitive. So having more resources, more equipment would allow us to do more robust testing to identify NPS. There's also that difficulty in detecting substances that are present in trace amounts. If you remember the blue tablet earlier on the GC, it was a very small peak and the match quality was not good. That's because of the low concentration of fentanyl in the sample. We had to go to the LC in order to identify it properly. There's also backlog and other resource constraints. International cooperation. As soon as we start issuing alerts, we'll share those alerts with CCAD's early warning system. We are aware of the UNODC's early warning advisory, but we do not contribute to the EWA. From the UNODC, we report to UNODC the substances that we find when we do the UNODC ICE exercise. Regarding supporting the analysis of samples from neighboring countries, this remains a possibility. There has been a number of attempts in the past, but they have been met with challenges such as obtaining import and export permits and a need for additional resources. But this is something that we're willing to do. And that's the end of my presentation. Thank you.
Thank you very much, Tracy Ann, for that presentation. Very interesting case study that you showed, and challenges of detecting substances that are in trace amounts. I think that's a challenge for everyone else. I think the whole issue you raised about international cooperation, I'm happy to hear that Jamaica is willing to participate, but you outlined some important challenges that we will need to overcome. You know, the permits that you need to export the samples and to import them. And then obviously you would need additional resources if you're providing services for other countries as well. So those are some very key issues that we need to wrap our heads around and see how we can resolve. But thank you for raising those and for explaining very clearly the situation with the laboratory in Jamaica and your relationship with the early warning system there. Thank you very much, Tracy Ann.
Thank you too.
All right. So we are doing very, very good on time. So I will now move on to St. Lucia, and we have Miss Lakeisha Cavalier, who is a forensic drug chemist. Lakeisha is going to present on behalf of the Forensic Science Laboratory in St. Lucia. Lakeisha, the floor is yours.
Thank you, Mr. Clark. Can everybody see the presentation?
Yes, it looks good, and we can hear you clearly.
Okay, thank you. Okay, so all right, so our role at the St. Lucia Forensic Science Laboratory is to identify new and unknown substances as well as their modified versions. Thereafter, we share our results to our stakeholders and support any policy and risk assessment. So our ability to test and identify controlled substances is twofold. We have chemical and instrumental analysis. And our chemical analysis may not allow us to identify more than just the drug, but instrumental analysis through GCMS, a gas chromatography mass spectrometry, allows us to identify any adulterants in the samples that we receive. The data that so we normally provide information for the purposes of court, but we do not have to wait until court proceedings in order to share those results. So that we're able to get the early warning system response going quickly, as we will see later. So I spoke of our instrumental analysis. The GCMS is a very robust instrument, and it allows us to identify a large number of substances. So we have access to databases that allow us to match the spectra so that we can identify our substances from our samples. Challenges and limitations. Okay, so with the quick emergence of new psychoactive substances, one main thing is legislation in terms of the substances being part of our laws. Another thing is obtaining reagents and standards. Currently, our suppliers are Cerilliant and Sigma Aldrich. We also obtain standards through the ICE program. And another challenge or limitation would be playing catch up to being able to identify those new NPSs, because we need to sometimes we may need to develop new SOPs for those new NPSs. On an annual basis, we inform the Ministry of Health on the number of cases that we do pertaining to each drug type. I also mentioned earlier that we have, sorry. On an annual basis, we submit our results to Ministry of Education to let the Ministry of Health, to let them know of the drugs that we that we encounter on a yearly basis. We're able to, and this in turn can feed into the EWS. We are guided by the Drugs Prevention of Misuse Act, which lets us know what substances are controlled, and that would guide our reporting. Here we have our stakeholders. In addition to the lab, we have schools, Customs and Excise, Ministry of Health, law enforcement, doctors and medical professionals, parents and civilians. How this works is if anyone obtains a physical substance or exhibits symptoms from ingesting such substance, they would feed this information into the EWS via our form. So a form is created for uniform dissemination of information. And recently, as early as December 19, 2025, we were able to put this into practice where we obtained MDMA, commonly known as Molly or ecstasy. So this was our first entrance into our early warning system. In the event that this is what our certificate of analyst looks like. In the event that we need to provide more information into the early warning system, there are other pieces of information that we do gather. So we are grateful for the assistance of the agencies pictured here. Over the years they have guided our SOP development and assisted us with training. Most recently, we were able to attend training at the DEA lab in Miami with the assistance of SCG and INL to assist in developing a new method for our GCMS using hydrogen. Currently, helium is what we use, but the sources of helium is low currently, so we are looking to an alternative carrier gas for our GCMS. So the St. Lucia Forensic Science Laboratory is ISO 17025 accredited under A2LA, and this was received in July 2022. What does this mean? That our methods are validated and that the processes that we follow are of a high standard. The results are traceable, reproducible, and legally defensible. Our equipment is calibrated and maintained. So our balances receive calibration yearly, and we have a maintenance contract for our GCMS. We have staff competency through training and authorization. We ensure quality assurance through audits and proficiency testing. And the lab is recognized as competent to perform forensic analyses. And results are internationally accepted and comparable across accredited laboratories. So we spoke of proficiency testing in our as part of our quality assurance. This allows us to validate our methods and to ensure that staff is competent and to correct any issues with testing if any. We do proficiency testing through CTS and through ICE, and ICE also provides our standards. And lastly, our EWS would feed into other regional organizations such as CICAD and UNODC. Thank you. Any questions?
Thank you very much, Lakeisha, for your presentation. Very succinct. I have a couple questions, but as I said, I will save it for the Q&A session. Thank you very
Thank
much,
you.
Lakeisha. So you're also accredited ISO 17425. That's interesting. All right. Who is next? I think we can move on smartly to Miss Michelle Nasir, Deputy Director of the Forensic Science Laboratory in Trinidad and Tobago. Michelle, you have the floor.
Thank you very much, Purnell. Always a pleasure to see you and the other participants and panelists. Thank you for the invitation to share the experience on Trinidad and Tobago and the laboratory's role in the EWS. So I'll just share my screen and you can confirm that you're seeing it.
Yes, you're good.
Okay, so
You're
this is
seeing
the
it, yeah.
Trinidad and Tobago Forensic Science Center. We do have multiple departments at the center. One of them is the chemistry unit that tests for seized drugs, and the other is the forensic toxicology department that tests for drugs in biological samples. I am by profession an expert in the forensic toxicology department, but I have worked with the chemistry department in the analysis of the NPS drugs. I'm going to talk about the role of the lab in the early warning system, which was launched in Trinidad in 2018. And I've been a part of the early warning system since its inception in 2018. So I have to really structure and filter the information that I'm giving to you because there's so much information I wanted to share with you. So the lab, so I'm going to be talking about both the chemistry lab that analyzes the seized drugs and the toxicology lab that analyzes the drugs in the biological samples, all right? So we're going to show how we detect the new psychoactive substances, how we do monitoring and trends in drug potency and composition, how we share the information, what are some of the standardization and quality assurance measures that we use, and then we're going to talk a little bit about our international collaboration with external agencies. And in between, I'll be showing you some of the challenges and limitations that we experience. So right off the bat, how we detect the new psychoactive substances. We follow the UNODC recommended methods, both for the detection of drugs of abuse and disease drugs and for the drugs of abuse classes in biological specimens. The references are to the top of the screen. And for anything to be forensically defensible in court, we have to do two tests, a preliminary screen and a confirmatory test. For seized drugs, then use whatever is available. You can keep it as simple as possible by using color tests or thin layer chromatography results. Or if you have access to it, you can use the handheld Raman testing devices. The color test, again, there's a reference from the UNODC manual on this. This basically just narrows the results to the class of drug that may be present. We usually have a lot of the reagents present in the lab so that we can make the reagents fresh whenever we need them. And these are mobile. They can be packaged into small bottles and given to seizure agencies so that they can test in the field. As we did, for example, you're seeing the UNODC drug kit at the top of the screen, where they have the little bottles. They're all labeled. They give you all the color tests that are color reactions that are supposed to occur. And we duplicated that in the lab and give it to the prison agency that had no testing ability at the time, so that they could do their rapid screening tests for the things that they may seize in their operations. The Raman handheld field device, as we know, it can screen through packaging. But if there's a mixtures, and we have found that there are a lot of mixtures, the results comes up inconclusive. So Raman is a really good tool to use to protect the first responders from being exposed to the drugs. However, it can come up inconclusive. Antenna chromatography as well, we use that to separate the drug into its different components against a standard. For the screening test for the biological samples in the toxicology lab, again, keep it simple, use whatever is available. If you have the complicated, sophisticated instruments, such as the immunoassay testing instrument that I'm showing you in the picture, that is an enzyme-linked immunoassay setup for the laboratory. That requires expensive assays. These assays are also have shelf lives. So if they expire on your hand, you can't use them. So we use whatever is available. If you do have the test strips, for example, those just require you to add a few drops of the reagent to the sample well, or if you have the sample cups, you can use those as well, as long as they satisfy the cutoff levels that you are using as your indication of a positive or negative test. We do have recommended cutoff levels for these screening tests by SAMHSA, the Substance Abuse and Mental Health Services. This is but one recommended cutoff level. There are many that you can choose from. In terms of confirmation of the seized drugs, then in the Forensic Science Center, we use Fourier transform infrared spectroscopy, FTIR, and I'm pleased to see that a lot of the other labs have also shown that they also have these equipment. So equipment doesn't seem to be a problem for us so far in the presentations. This will, of course, use infrared spectroscopy, give us the different functional groups, and then match to the libraries in the FTIR. We also use GCFID to separate the samples and against unknown reference standards. And then finally, GCMS to confirm the presence of the drugs as well, matching it to the libraries that are available. We quantify cocaine by GCFID, and as well as we detect the presence of these new synthetic drugs by GCFID. In terms of presence of reference standards, we build capacity as we go along. So every year we try to buy, have the drugs available, and we add new drugs to that every time. So we do have a pool of reference standards available, both liquid drug standards that we purchase from Cerilliant, as well as the powder form of the drug that can last a little longer and are not subject to expiry dates. This is just an example of the 8890 Agilon GCMS application note that we use for the confirmation of the drugs by GCFID. As you can see, it can span in 28 minutes. You can detect quite a large category of drug in a sample. For the toxicology analysis of confirmation of the drugs, however, it's a little more sophisticated. As mentioned before, we can't just put a blood or a urine sample onto the machine. We have to first extract it. We do use solid phase extraction. And then we have to derivatize to protect the molecule when it goes on the machine so it doesn't get chewed up and can survive to the detector. But our GCMS system is a little special in that we have this two-way splitter in the oven that allows us from the one injection to divide the sample into two, and it goes to two detectors. The first detector is a mass spec. The second detector is an NPD, nitrogen phosphorus detector. And most drugs do have nitrogen in them, so it allows us to detect the drugs in the NPD. And then we also use that detector for the analysis of poisons, because most poison substances contain phosphorus. We purchase quite a bit of libraries at considerable cost so that these libraries are good at the time of purchase. So new drugs that may occur on the market would not be present in the libraries. So we use Strict Drug to keep our libraries up to date. Strict Drug has, as shown in the reference there, Strict Drug has mass spec libraries available free of charge. You just need to download it and install it on your data analysis system. This example of us sending a sample through our procedures, screening first by Raman device, it picked up methamphetamine, analyzed by GCMS with simultaneous NPD. We picked up the methamphetamine in both the GCMS chromatogram at 9.825 minutes, and then also in the NPD at 9.849 minutes. We also picked up the adulterant that was present, which is caffeine in our results, and then we have the library match. Just giving you an example of how many we have a match of 89%, how many different libraries that we have available, and how the matches look. One thing I wanted to point out was that this simultaneous MS-NPD allows us to satisfy our requirement to having two different techniques to identify, to unambiguously identify a drug. This is taken from the Strict Drug Scientific Working Group strategy for the analysis of drugs, in which they say at least two tests based on different properties of the molecule should be used. So if, for example, you only have a GCMS, then you have to use retention time and the MS, as Tracy did, two different solvents, so you see the times will change and so on. For us, as I said, we use GCMS as well as GCNPD. That could also be satisfied by using a color test on FTIR, for example. If we don't have this standard, then we also use spectral matching to the mass libraries. And moving on to reporting, we do have, as part of the early warning system, so the lab classifies the drugs as Pranav mentioned. I'm showing you the different techniques that we use. We report to the early warning system using our detection form. Every drug class, every synthetic drug, not every drug, every synthetic drug that we find is reported to the early warning system using this detection form. Item 12, as circled, as highlighted on the screen, is where we will put in our information, what our case number was, the date and type of drug that was detected. All the other fields of this, if available to us, will also be filled in, or it will be filled in by the seizure agency. And how do we communicate this? To the early warning system, we have meetings once a month. We have a subcommittee. So we have the entire early warning system committee, and then we have subcommittees. The subcommittees meet more regularly than the larger early warning system stakeholders. And in this subcommittee, we share information very quickly by WhatsApp or by having our regular monthly meetings as the findings and what persons are seeing. So in that subcommittee, we will have the seizure agencies. So Customs and Excise is there, Coast Guard, Police Service, Ministry of Health, Drug Inspectorate, and Forensic. We all get together, and prison as well. We all get together at least once a month. We try to meet once a month, and we will share what each other is seeing. If something is happening that needs to be addressed very quickly, we can call a special meeting. Any one of the agencies can call a special meeting to share information. If we're seeing something on social media, we'll also put it there and ask, is there any feedback? Is there any confirmation of what we're seeing, and so on. In addition to this, we try to sensitize, for instance, try to sensitize at the invitation of the different policy agencies to share the information we are seeing as well with regards to the new synthetic drugs, whether it be by having television interviews on radio or doing webinars, however they think that we can contribute As I said, we were there from the inception of the early warning system, and we have stepped out of our traditional role of giving testimony in courts of law. As well as doing that, we also try to be involved in the sensitization of the presence of the NPS drugs, because we've seen quite a large variety of NPS drugs in our population. We report internationally from very early on. We started in 2018. From the time we started seeing these NPS drugs, our laws were changed in 2019. So ecstasy and so on are listed in our laws. So the true NPS drug that we are seeing in our environment is ketamine. Ketamine is not listed as a psychotropic substance in the 1971 convention. So when we see it, we report it, and we have seen this is the drug that seems to be the drug that is on the rise in Trinidad and Tobago in terms of use. As you may know, ketamine is a drug used legitimately for medical purpose, for anesthesia, but it is being abused in Trinidad. So we report it on the early warning system. Whenever we find it, we also report it on the Global Rapid Interdiction of Drugs, the GRIDS Ionics. There is someone from the Forensic Science Center with the logging credentials to update the information that needs to be shared whenever we have a seizure at a port of entry. We have international obligations with the International Narcotics Control Board to provide the statistics and our findings, both on the Form C and Part 4B. I'm showing you for 1 year, once a year, we have to give this information to the Ministry of Health, our competent authority, who is also a member of the early warning system, and they then will relay it to the International Narcotics Control Board. As you can see in this picture on the screen, in this particular year, we had 37,300 milligrams of ketamine seized that year. So because we are the only forensic science center for both Trinidad and Tobago, it helps that we are the central, all the information is centralized at our department, the chemistry and toxicology department. We do liaise with the National Alcohol and Drug Abuse Prevention Program. They will do the treatment providers, liaise with them directly, and so on. So from information that I got from NADAP, the National Alcohol and Drug Abuse Program, they did a survey of the drug treatment provider clients, and we were able to extract from that survey, they are a member of the early warning system, extract from that survey the trend in drug of choice amongst the persons in treatment in the treatment centers for the period 2018 to 2025. And this was a bit eye-opening for us. And we only did it last year. We did the chart for 2018 and 2025 last year. And we were seeing in both female and male clients the presence of LSD. We expected to see the amphetamines, we expected to see the mushrooms, because we do have seizure cases for those. We do not have a seizure of LSD submitted to the Forensic Science Center for us, any one of the sections, for us to confirm the presence of LSD being used in Trinidad. And what is also surprising is that there's no ketamine being reported by the persons who are seeking treatment in treatment centers. So again, we do provide information such as the number of cases that we have received per year, and we are charting that, whether it be by a bar graph and by line graph, so that we can easily show which one is trending upwards, which one is trending downwards, which one is the one that is most prevalent. So this is the drug trend by number of cases. We also monitor and look at the trends of the quantity of the drugs that have been seized each year. So that, for example, in 2025, for the first time since its inception, we have ketamine being the largest seizure of synthetic drugs. For the first time surpassed ecstasy. This information was shared in the early warning system and has now triggered an alert which is being crafted on ketamine. Our judiciary partners are very much interested and provided the information for us in terms of looking at the number of arrests involved in synthetic drugs. And then if we do have to present the information to the heads and the policymakers and so on, we try to put in not only the trend in the trending lines and the charts, but we also try to put in the pictures and we give them all the data that they need so that scientifically driven policies are generated. So in this picture, for example, on ketamine, not only are we showing that it has increased drastically in 2025, we're showing them pictures of what it looks like. We're not only seeing medical diversion from veterinary use, but we're also seeing persons bringing it in as the white powder seized by customs and excise. It's being camouflaged and hidden in containers. And we've also seen pink cocaine, which contained no cocaine. It contained ketamine and MDMA. This was reported on the INCB and it's on the grids as well. And then we're seeing ketamine being camouflaged in ginger tea, for example. So I tried to streamline what I was going to present to you all. So I know I'm going to be going over time for a few seconds more. In terms of standardization and quality assurance, we again follow the UNODC guideline for the violation of analytical methods. In terms of the frequency and type of calibrations that are done for both biological and seized drugs, these references are very helpful in telling us the exact tests that we need to perform based upon the type of method that we are using. We also follow standardized recommendations from SWIG Drugs, Scientific Working Group on seized drugs, as well as SWIG Tox, which is a scientific working group on forensic toxicology. Some of these experiments I'm showing you, we did the one for GCMS on marijuana. We would look at the parameters that have been monitored and the actual experiments that were done. Lastly, in terms of proficiency tests, as mentioned previously, international collaborative exercises, ICE, run by the UNODC, we do participate in these as well as these collaborative testing services for both biological and seized drugs. And this, again, as already mentioned, gives us the confidence in our results and ensures the reliability and performance of our staff, as well in detecting the different NPS drugs. So with that, I thank you for your attention, and I'll be waiting for any questions that you may have. Thank you.
Thank you very much, Michelle, for your presentation. Very, very informative. Lots of good detail. I am going to reserve my own questions, and I'm going to open the floor. I think we've been at it now for an hour and a half. And I don't think, let me check, I don't think Cheryl is available as yet. So I think I'm very happy to open the floor for any questions that you may have. There is a Q&A button at the bottom of your screen where you can type your questions, or you can just drop them in the chat and let us know what your question may be. If I can ask all of the panelists to please turn on their cameras so we can see you. And then I'm going to go to the first question, which is for Mr. France Delon. You have a question from Suriname, from Sabrina. It says, so if I have seen correctly on one slide, The detection of substances can be obtained within 24 hours from the lab in Guyana. So can you confirm that?
That would be the slide with the NMR, which we have future plans. That's what the slide that says future plans with the new equipment, the NMR. However, within 48 hours, though, with our current capacity, we can have results available. But with the new equipment that we propose to have on board, that equipment can produce results within 24 hours.
Okay.
And those results would include the composition by percent of each compound within a submission or a sample.
All right. So let me so that I am clear. Your current capacity allows you to have results in 48 hours. But if you do get the NMR machine that you mentioned in your presentation, you can cut that down by half, 24 hours. All right? Either my connection is slow or Mr. Francis' connection is slow. Oops. We lost his video. Did I get it correct?
Yes, we can with the new machine, specifically to support the early warning system. We can achieve that goal.
Okay, so you are getting the machine. It's in the works right now. It's coming.
We propose. It's in the works. It's in the works. It's in the works. We propose it in our budget, but we have to wait and see.
Okay, well, I hope you get it. We were in Rome recently, visited some labs there, and that seems to be their new standard. That they love the NMR machine. So hopefully you do get it. Hopefully you do get it. All right, thank you, Delon. So the next question, if I can see it here, if I can pull it up. Does the laboratory, it doesn't ask specifically who they want to respond, so I'll make it a general question. How does the laboratory handle the reporting of results for any NPS or other controlled substance for which there's no reference standard available in-house for comparison? I think anyone who wants to can take a stab at this question, any of the experts here. I'll repeat the question again. How does the laboratory handle the reporting of results for any NPS or other controlled substance for which there is no reference standard available in-house for comparison?
Okay, I can say what we do at our lab. When we're reporting something like cocaine, which is on our library, we say that it is confirmed because it is in our library. But if it isn't, then we can say that the sample, the substance is indicated in the sample. It has been detected. That's how we handle it.
Okay, thanks, Lakeisha. Any other comments from any of the other panelists on that?
I can add. So as I mentioned, we do have multiple detection methods. Yes, some with more confidence than others. So when we have a sample that is unknown and we analyze on the GCMS with MS and NPD, and we detect it and we don't have a standard, we do library matching. And we have a criteria that it must be, I think, 70% and more of a match for us to be confident that it is the result, even in the absence of a standard. Because, for example, there will be no standards for new substances like nitazines and xylazines and so on. So you can be confident that once it matches that you can report it, and then subsequently you can try to acquire the standard and confirm using the same retention time match on all of that. But we're using two confirmatory techniques. MS NPD is doing library matching, and once it's over 70%, we are confident to report it without a reference standard.
And from a legal perspective, that confidence level is acceptable in your legal system for prosecutorial
Yes,
purposes?
GCMS is usually viewed as the gold standard for us. It allows us to unambiguously identify a substance. And as I said, if there's any degree of hesitation on our part, they will hold the case back until we get the standard and then do the confirmation. Otherwise, we do report it. We don't have 48 hours. We can report a case, probably in 6 months or so. It all depends on when it's available, ready for court.
Thank you for that. Let me just check the chat. Yeah. Someone was Mr. Codrington, John Codrington, I think that's from Suriname as well, was asking about the PowerPoint presentation. So we will consult with all of the panelists and make sure that we can share PDF copies of their presentations with all of you, right? We usually will do that. I'm getting a message. Paula's helping me here. We have a question from one of the participants, and Paula's going to give him the floor. Go ahead, Paula. Mr. Thompson, yes. Go ahead. Dr. Thompson, right? Yeah, Dr.
Hi there,
Thompson.
yes.
How are you? How are you doing, sir?
Well, it's wonderful seeing you.
Good to see you as well.
No, it's really a pleasure. I want to tell you that I have been really impressed with the presentations and several things with Trinidad. As you recall, when we were in Jamaica about 2 years ago, it was cited that there was a warning about ketamine, and to see ketamine come up in Trinidad, I'm a little surprised that it's now the largest and not being a stone step away in St. Vincent and the Grenadines. We certainly have to take that warning. We certainly don't have the ability to do those particular type of testing. I have not made any seizures. And the question I would have put to her is, what age group? We've heard about the youth gang, 6s and 7s. Are we seeing ketamine in older entities? And I know she may not have that information from a testing point of view, from a profile of individuals, but is it, going a little further in terms of early warning, is it youth, the teenagers and so forth we're seeing that with, or is it older groups and so forth? That's the first question. Now, Hernel, the question for you is, clearly I come from a background more that I am the chief executive officer of the Medicinal Cannabis Authority. And we have our own lab. The lab, we're just getting it back functional, is able to do all the whole range of testing, to do the certificate of analysis and so forth, and all the equipment that's been cited. And essentially, with the fact that 8 islands in the Caribbean have now legalized for medicinal cannabis, and are looking at that, and we see the United States with rescheduling and so forth, in terms of it being moved to Schedule 3, and the potential, even though the INCB and CND hasn't done the same thing, but in terms of if it's a Schedule 3 and the reportage and all the sort of issues and so on would come up, how do you see that this is looked at? But still, from a regional point of view, there is a limited number of tests. And so I see all these facilities in Jamaica, in St. Lucia, forensic units, and so being able to do testing. And the problem is going to be, how do you fly it around with, first of all, limited carriage, into Caribbean, LIAT, all this other thing? How do you really move the product around to get quick, accurate testing and so forth, and get the results back? So I've thrown out a number of things, but I wanted to know a little bit more about what's happening in Trinidad. I wanted to know from your standpoint, Pernell, of with the United States rescheduling, what does that mean? And so with respect to cannabis, not so certainly with cocaine and ketamine and all these other things, other MPSs, but and then from a regional point of view, I'm sure they will come in. How do we leverage the regional testing and so forth in a better way so that results can be obtained very quickly to allow for law enforcement to take action and the court system to take action. But at the same time, in the case of cannabis, again, accuracy and patient access to quality products. That was my long question, but I just thought I'd throw that out.
Okay, thank you, Dr. Thompson, for your two questions. I'll answer the second question first, and then pass the floor to Michelle, who I'm sure will have some idea of what's happening with ketamine use in Trinidad and Tobago. So I think I understand your question. How can we leverage the analytical capability in the countries that are here presenting and others to support testing for medicinal cannabis? And I think the challenges that Mrs. Bennett mentioned during her presentation for samples of illicit substances would also apply to medicinal cannabis. I think every country has its own law. All of the laws, as far as I am aware, are not exactly in sync in terms of the quantity that is penalized, the quantity that you can have for personal possession, etc. So each country has its own specific law. That means that you need to have some sort of a provision in the form of an import license, an export license, chain of custody, procedures, and all the rest of it. So the same issues that affect sending samples of illegal drugs to another country for testing would affect medicinal cannabis. So I think this is something that we need to discuss. We've had some internal talks about it. This is something that obviously requires some legal input. We need to have the Ministries of Legal Affairs, AG's offices, and other offices across the region to guide us on this topic. I know that countries currently send samples to Miami and other parts of the USA for testing when they do not have the capability in their own jurisdiction. But that involves, a lot of money, a lot of patience. Sometimes it involves an actual officer, either a law enforcement officer or an officer of the core of the lab, traveling physically with the sample to the country number 2, waiting for the test to be done, getting the results, and going back home. So it is quite an involved process, Dr. Thompson. But I think from a macro level, the same challenges that apply to illicit substances would likely apply to medicinal cannabis. So I hope I answered your question at least partially. There's not an easy solution right now, but this is something. I mean, I can only tell you what I envision, what I would like to see. I would like to see some sort of regime where there is some sort of uniformity across the region, at least this sub-region, where, those licenses, the way they're issued, how they look, the forms that are used, the information that's required, that the authorities communicate so that it's easy for this to happen. I think, for example, if DeLon gets his NMR machine, which, as you can see, will significantly reduce his testing time and increase his capability, that every country, once he has the capacity, should be able to send samples to DeLon, pay, you have to pay for it. It's not going to be free, but send the samples to DeLon in maybe high profile cases or urgent cases so they can get results in a shorter period of time as possible. But that's just a pipe dream. There are legal impediments that we have to overcome, legal hurdles that we have to jump. And that's, I think, one of the phases of this activity as we move forward to try to break down those barriers and facilitate that. And then to your first question, I will hand the floor over to Michelle, I think the question was on, who's using
Ketamine.
ketamine in Trinidad and Tobago.
Yes, thank you, Penel. So we have seen ketamine, access to ketamine increase. First, it was being diverted from medical use, legitimate medical sources. And once the Drug Inspectorate started clamping down on the pharmacies, for example, on hospitals, then we started seeing it being brought in as the white powder and being seized by customs and excise. In terms of use, we're seeing it among human trafficking cases, drug facilitated sexual assault cases. In one instance, it was being sold from a private pharmacy to clients. And then we do have law enforcement seizing it on the streets, being sold as the pink cocaine to whomever is interested, right? And that had ketamine in it. Remembering that the name of the drug was pink cocaine, so people could very well think they're buying cocaine, when in fact it is ketamine present in the sample. I showed you the graph from the National Alcohol and Drug Abuse Prevention Program. Hi, Cheryl. And none of the participants said that they were using ketamine, but that data, that survey that they did have all the ages of the participants, and it's a wide range of persons exposed to the drugs. So I'll come off now so Cheryl can come in.
Okay, thank you very much, Michelle. Before we go to Cheryl, I'm glad you were able to make it. Thank you very much. Okay, yeah, take your time, and when you're ready, we'll get to you. Just let me know when you're ready. Michelle, the data from treatment that you showed,
yes,
that is largely self-report data.
Yes.
Correct? Because as far as I'm concerned, there's no testing being done at entry across the board for the treatment centers.
So this is what this is what they think they are using. This is what they are presenting in treatment for. And they will list their primary drug as well as their secondary drug of choice. A lot of them are alcohol, but others are strictly synthetic drugs. Who is addicted to oxycodone? Who's addicted to the benzodiazepines? Who's addicted, right? But no one said that they were in treatment for ketamine.
Yeah. And I think the point I wanted to make with that particular issue, no one said they were in treatment for ketamine, is you showed in one of your slides with the different forms of ketamine, you actually showed pink cocaine. Yeah. Which, as for those who don't know, there's no cocaine. As you said, there's no cocaine. In pink cocaine, it's a trade name. It's essentially a street name, a trade name, and it's usually ketamine mixed with, a variety of other substances, MDMA, meth, etc. And I think one of the challenges we face with the treatment data is that, as you said, people don't really know what they're using. Yeah, but at least there should be some congruence between what they're reporting, or at least what they think they've been using, and the seizures and the other data that you have. So I think this gives us an opportunity to see if we can get some more testing in the laboratories.
So let me just add, we do have drug treatment courts in Trinidad and Tobago. So persons who volunteer to go into drug treatment as an alternative to incarceration, for them to be admitted to the court or to treatment, they have to be tested. So that's where we use the dipsticks. We train probation services, we train the treatment providers in health and so on to do that that weekly testing to monitor. But the first sample for them to be admitted comes to forensic. And we do the screen to see what drug they have to. So in other words, they have to present as positive for a drug for them to go into drug treatment. And that's where we get, so that first testing is done by forensic for drug treatment admission, and then it's monitored with the test strips to monitor compliance to their program. So we do have some data for the drug treatment in that regard. but not for the long-term treatment providers who are not part of the drug treatment court program.
Okay, thank you very much, Michelle.
So,
Um,
quick question.
Go ahead, Delon.
With regards to the drug treatment court, the testing the follow-up testing that is being done, is it the qualitative test, or you do the quantitative testing to monitor the clients?
Just the qualitative test, and then we'll also look for the adulterants in that test. So, and the test that we're using, the cutoff is what's going to help us determine whether or not the sample is positive or negative, and if they have actually used, because they're going to say that they were exposed to secondary hand smoke or something like that, for example. But we tell them no, at the level that we set, it has to be positive from use. If there's a challenge, if they challenge the results of the test from the probation or the providers, then the sample comes to forensic to confirm. But we only do the initial screening test to see what drug they were under the influence of, or what is their drug of choice.
Oh, okay. Thank you. Thank you for that.
Okay, brilliant. Just a couple more questions before hopefully we move on to Cheryl. So there's a question, thanks to St. Lucia and Trinidad, just to follow up on the reporting of the NPS results. Do you require validation before I think I lost the question. Yeah. Do you require validation before reporting on NPS testing? That's the question. I'm not sure if you can respond, Lakeisha.
Yeah. So, well, if I understand the question correctly, validation is important in terms of reporting, especially when in regards to legal cases. So you would want to be reporting on results that are reliable and accurate, because you don't want you want to prevent wrongful convictions. And also from an accreditation perspective, you want to report on validated methods that are of a high standard. Yeah.
Okay. Thank you very much. And I
there
guess
are some simple things that you can do as well. I'm talking of from experience now, to make sure you have your quality controls and assurance is in place. You can run simple thing as running blank samples between analyses to show that there's no carryover, for example. You want to run a positive and negative control if you're doing the preliminary screening and so on. In the absence, so especially for drugs that you're not accustomed seeing. As much of the you want to show that there's no interference from your matrix, whether it is blood or urine. So you want to extract a blank urine, for example, or blank blood, and run it through to make sure there's nothing showing up in a blank sample that could be mistaken as the sample. Little things like that. Run the other standards, so you eliminate the other standards, because a negative result is also information. So you're looking for amphetamines, for example, and you make sure that the cocaine is not showing up there. You make sure the opiates is not showing up there, etc. Have different things that you can use to build confidence in the results by implementing quality control and quality assurance mechanisms.
Thanks, Michelle. Okay, just a couple more comments. I see Stanley Cox sent a note. There's a significant amount of collaboration which happens across the medicinal cannabis industries of the Caribbean as already established. I think that is in response to Dr. Thompson's questions. And then Elizabeth Chapal from Grenada is asking, well, first she says outstanding presentation. So that's kudos to you, the panelists. And is asking whether there'll be another opportunity for such sharing, so that many more stakeholders can benefit from this very important information. Yes, Elizabeth, we will try to have these and similar types of webinars going forward for sure. And laboratories, as I mentioned in my opening remarks, having laboratories as part of the early warning system is critical. So we will be spending some time on this going forward. So hopefully you can have much more of your folks participate in the next such event. So Cheryl, I think we are ready for you. I have not received your presentation. I'm checking my email. So is it possible that you can share from your end?
Yeah. Oh, good morning, everybody. Sorry, I was dealing with meetings with our new minister, and thank you for being patient. Yeah, I think I should be able to share it from this end. Let me pull it up and okay, hold on. Okay, all right. And okay, share screen, share. Okay, here. What's coming up? Why can't I see that? Share. Oh, right. Okay. Can everybody see that?
Yes.
Yeah?
It's, yeah. If you can put
All
it
right.
in
Yeah, I
presentation
got put it.
mode, then
Yeah. That should be okay. Great. So everybody can see that, yeah, right? So
yes, good to go.
So I can start. All righty. All right, let me start again. Good morning, everybody. And for those of you who don't know me, my name is Cheryl Corbin. I'm the director of the Forensic Sciences Center. We are now under the Ministry of Justice and Ministry of Legal Affairs, and Criminal Justice. And what I want to do today, as quickly as I can, is to work through the critical role that forensic and toxicology laboratories play in the Caribbean's early warning system, especially as we are faced with a rapidly evolving drug landscape. Our region is small, but that doesn't mean that the threats are small either. And our labs are at the front line of detection and protection. Now, I want to start. All of us know what the early warning system is, and but the drug market is changing faster than ever, and new substances. Hold on a second. Hold on 1 minute. Right, and new substances. Right. And new substances, the market is changing quickly because of the new substances and so on. And the forensic toxicology labs are essential because we provide the scientific evidence that allows the public health and law enforcement to respond quickly. Okay. Now, we do have our vulnerabilities in the Caribbean, which would be our small populations, tourism, our borders are fairly porous. So early detection is even more important in that circumstance. Come on. Right. So what is an early warning system? And as I have there, you can read that easily, but it allows us to issue alerts to guide the public health responses and to support law enforcement. And the two mandates are fairly quite self-explanatory in that, as far as we're concerned in Barbados, the EWS protects the public health and it also assists law enforcement. And we in forensics, we provide the information that feeds into those two pillars. Okay. Now, for regional coordination, we don't operate in isolation because these other agencies, we work closely with CARICOM, with CCAD, with UNODC, and all of them help us stay aligned with the global trends. We get a lot of intelligence information from them. And our lab contributes data to the international monitoring systems. And in return, as I said, we receive the alerts and intelligence. And that helps us prepare in ensuring that we have methodologies on our instruments that can identify those substances that are not the norm that are that we would see for when the police submit their cases. So this regional and global coordination is what strengthens our resilience. Now, what the Caribbean needs EWS, because drug markets technically have no borders and substances move faster than law enforcement can keep up in most instances, especially with the new online sales and international shipping. People try to do that, and send them through your post office and hope that the officers there, that their ignorance or their non-familiarity of the way how some of the profiles of these drugs would be physically, that things would get through. So we're seeing more synthetic stimulants, synthetic cannabinoids, and even opioids entering the region. And the tourism and trade routes increase our exposure. So obviously early detection is not an option. It is really very essential. Now, where the labs come in is that we actually identify the psychoactive substances, we confirm what's actually in circulation, and provide toxicology evidence when people fall ill. And in some cases, they not just fall ill, but sometimes they die. So we support hospitals, customs in Barbados, or NCSA, which is our National Council of Substance Abuse. TBPS is the Barbados Police Service, and we also support other regional partners. And importantly, we report very rapidly. So when we get a suspected case, or turnaround time, sometimes it's less than 24 hours. Now, as far as the scientific sections within FSC is concerned, these are the 5 sections that we have within our department, which should be fully operational May coming. But for EWS purposes, it is primarily chemistry and toxicology that you'd be looking at. Now, as far as chemistry is concerned, so that you would have some idea what's actually done to support the EWS within the lab, our chemistry team's work is very rigorous. Every case requires using validated methods, having proper chain of custody, quality assurance, and detailed reporting. We use multiple analytical techniques and reference materials. Most of our reference materials are actually acquired through the UN. And sometimes where the toxicology reference material is concerned, which would be more metabolic or metabolite-based substances, we would get those from authorized pharmaceutical companies. And we do have to get the licenses to bring those in. But our work, even though I said 24 hours, yes, but doing the work itself, you have to be very diligent. It is slow, must be careful work. And it's the foundation of us being able to give a reliable early warning to the public and the powers that be. Our capabilities, as it stands right now, we have GCMS. Within the next 6 to 8 weeks, we will have LCMS, and even SEM and some of those other things. But our staff are trained to detect the emerging NPSs, which are the new psychoactive substances. And this is increasingly important as more of these substances evolve. And this is also why the coordination with the other agencies overseas that can provide us with the intelligence, inclusive of CCAD, because when you give us the flags and so on, we're in a position to identify the methodologies that we need to use so that we can do the analyses. Even if we don't have the controls, our data libraries, the libraries for the instruments, would at least be able to assist us in the direction to know what we are looking at. Okay. Now, the new psychoactive substances are designed to mimic traditional drugs, but often with far more dangerous effects. And they fall into 4 major categories, which are the synthetic stimulants, cannabinoids, hallucinogens, depressants, which is inclusive of the opioids and the benzodiazepines. And the challenge is that their chemical structures change constantly. This is almost kind of like, I guess I aged myself, like the time when the new designer drugs were coming out. It was very difficult at that point for DEA and some of those other agencies to keep up. So we are like in a similar situation, but a little bit more advanced. But our staff are constantly being trained to detect these NPSs, and this allows us to stay ahead of the threat as much as we can. Now, the Caribbean laboratory experiences. Now, across the region, we are seeing synthetic cannabinoids and opioids. We are also seeing polydrug use and adulterants, substances mixed together in unpredictable ways. There's an increase in the risk of, and this increases the risk of overdose and severe reactions. And the rapid reporting and harmonized data are essential so that we can respond collectively. So again, when we at our labs get information, we we send that up to NCSA. NCSA sends the information in the alert to CCAD, and then it is distributed to the other agencies via that mechanism. Okay. There's no reason, however, why within that we could have unilateral relationships with labs within the region. And I will just say this, that when we do open again, that's one of the first things that I'm going to do with the Forensic Sciences Center. We need to re-engage with all the labs in the region so that we will know what our capabilities are and how we can help each other. All right. Now, I just wanted to give you one case example here. In 2022-23, we had our first DWS alert, and it came from stimulant tablets containing MDMA, methamphetamine, and in some instances both. And these tablets were branded Heineken, Punisher, Farah, and it was obviously designed to appeal to young people. And the combination of a stimulant and a psychedelic obviously increases the risk of harm. And this case showed us how important early detection was. And what I'm going to do right now is just flip through very quickly so you can get an idea as to how some of these drugs looked in tablet form when they were presented to our chemistry section. Right. Now, in 2023, we also had another situation. This was our second EWS alert. It occurred in August, and it involved the plant-based material, which is laced with MDMB4EN Pinica and 4FMDMB Butica, which are two potent synthetic cannabinoids. The sample came through NCSA. It did not come through the police. It came in as a result of a very viral video that was going around where one unfortunate gentleman evidently became very catatonic when he imbibed with the substance, with others spurring on, telling everybody on Barbados that, yeah, he's the supplier of good weed. Well, that's all it is. So, and then what happens is that because that video went viral, social media actually became the driving point of distribution and information for this particular drug. So we had to deal with the alert very quickly. Okay, why synthetic cannabinoids are dangerous? Primary reason is because they mimic THC, but they're far more potent and unpredictable. And they've been linked to seizures and collapses and spasms. And one of the main challenges here is that when persons are presented to hospitals with these symptoms, they don't, the medical fraternity doesn't necessarily have an idea that this is coming from a synthetic cannabinoid. They're thinking other things, So again, we have to work with the medical fraternity to get the information to them so that they would understand the presentations. Now, unfortunately, this is not a situation where we have information from years ago. Is that the information has to be being gathered as we go along and hopefully analyzed and distributed as best as we can. Now, in 2025, we had another alert. This case, this is our most recent one, and it was to do with a royal honey seizure. Now, Unfortunately, I don't have the image here to show you, but the products were found in a small retail store and contained HHC and Delta 9 THC. These are semi-synthetic cannabinoids and marketed as legal alternatives. Now, the packaging was extremely attractive and clearly designed to appeal to customers. And this case shows how quickly new substances can enter into our market. Now, what are these semi-synthetic cannabinoids? Now, these are the chemically modified cannabinoids designed to mimic THC while avoiding legislation. Okay, well, legislation as it stands, which is a whole other issue because you really now have to look to see how you can widen the language and your legislative instruments to give them the umbrella that they need to have, bearing in mind that the formulation of these drugs are changing rapidly. Okay. Now, these drugs, as I mentioned, they're increasingly global and they're harder to detect with routine toxicology tests, which means that they can circulate unnoticed. And this is now becoming a growing concern within, well, for us in Barbados especially, but and I would say within the rest of the Caribbean. Now, the health risks of HHC, similar to the other cannabinoids, to the yeah, to the clinical and so on. Anxiety, panic, confusion, hallucinations, but we know far less about its long-term effects because these are drugs that are now on the market. So it's like we gotta, unfortunately, it almost seems as if persons have to, be negatively impacted for us to get the positive data that we can use to assist other people going forward. That's an unfortunate situation, but I don't think it's one that we can necessarily avoid, right? Now, the legal implications, at least as it relates to Barbados, and I'm sure that this can be for discussion if you have time with other countries. Under Section 20 of the Drug Abuse Prevention and Control Act in Barbados, it is illegal to sell or offer any product that claims to contain a controlled drug, even if it doesn't actually contain it. That's what we refer to as our purporting provision in the legislation. So it's like you could be trying to sell somebody white powder and telling them that it's cocaine and it's not. You're gonna be charged and you're gonna be fined and you're gonna be jailed just as if you're selling cocaine. Okay? And in this case, the Royal Honey had packaging listed on it that said it had in THC and THCP, which it actually didn't. And that alone constitutes an offense. Okay? Not just for the person who is purchasing it, but the person who is selling it. And this is where the big difference came between this alert and the ones we had before, is because we are now at a retailer store. And it's like they're trying to tell us that they're being ignorant of what they're selling and that they're making good money from it, but they don't know what it is. Well, ignorance of the law is no excuse in this particular circumstance, or in any circumstance, really. So that was one of the main things that we had to speak to, especially when these packages are very attractive for children. And so we also had to speak to the fact that there were a lot of vendors that are on the outside of the gates of schools selling things, snacks for the children to buy when they're coming out to school. So we literally put it out there that the principals of the schools need to really start looking to see what's going on outside the gate. Okay? Right. And as I said, why that this particular Royal Honey case matters, I'm almost done, is that it shows how quickly that these SSCs can enter our Caribbean market. And it highlights the gaps in the legislation and that we need for updated controls. And it also demonstrates the importance and the value of collaboration, that the existing collaboration between FSC, the Forensic Sciences Center, and CSC. And most importantly for us, it proved that the EWS here in Barbados is working effectively. Okay, so communication, between agencies, which be like your other agencies and your other countries, we think that the communication is the backbone for the EWS. That's how we see it. We report unusual findings, we use standard templates, and we need to meet regularly. The standard templates are important because then everybody understands the information that's being presented and how to deduce or make your deductions or recommendations out of the information that's being presented. And this will contribute to faster reporting and more harmonized data across the region. And because the more we are aligned, the stronger our responses are going to be. Now, some of the challenges for our labs is that we all have resource constraints, money, budgets, things like that, buildings. Well, we just experienced all of that. And not having the appropriate environments fit for purpose for our investigations. We also have the challenge of the fact that these MPSs are evolving. So the chemistry that has to match for the investigations has to evolve as well as that. And then limited reference materials. But again, even though we may not have limited reference materials, because these drugs are changing so rapidly, and because when we don't have controls, we rely heavily on the libraries that are in the equipment, like the GC libraries and so on. But then how quickly can they update their libraries to be able to satisfy what we have to do? And then there's a need for continuous training. Then there's the pressure of having the quick turnaround times, because it is not just a drug case that we are doing. We are dealing with a matter that can potentially become a major health crisis. It's a public safety issue. And, then that puts that health sector under more pressure with the limited resources that has. But despite these challenges, our teams continue to deliver the high quality scientific work. And this here is showing you the international collaborations that we have, so we know that we are not fighting alone. And FSC is expected to recommence full services in May. We are much closer than where we were before, right? And as far as we can see the way forward, agencies and those international entities who really have an interest of what is happening within this region, because then once we can identify and control what's happening within the region, our region is bottom bound to your borders. So it means that we are helping you as well. So we need to invest in laboratory capacity. We need to have data sharing, whether it be on dashboard platforms or whatever. We must be able to improve our turnaround times, but that is always linked to personnel and having the staff available at the right academic level and of training. And the public engagement is essential because the community is part of the EWS network, because we get information from them as it relates to what's happening out there. And for us in Barbados all along, we have just tried to emphasize to the public that you can come and give us the information. Don't be wary of feeling you can get charged for something. It is not a criminal activity at this point. We just need to get the information so that we can safeguard our community. So FSC is ready to play our part. And these are just a few points that I want to finish off with, that the labs are very essential to the region, EWS. Early detection saves lives, collaboration is key, global partnerships enhance readiness, and together we can protect our region. And thank you very much for your attention. And if there are any questions, queries, I'm here to answer. Thank you for taking the time.
No, thank you, Cheryl, for jumping out of your meeting with your new minister and joining us in this session. Very comprehensive presentation. And I will actually steal some of your material here. One of your slides had, if I can pull it up on my very slow computer, one of your slides had some of the challenges, and I think you summarized very nicely and in a very comprehensive way what many of the other laboratories expressed today. You missed the other presentations, but they were all saying the same thing, basically resource constraints. The fact that the NPSs are changing so rapidly, one molecule that changes the chemistry of the NPS. challenges in getting the reference materials that was mentioned by a number of the presenters, getting access to the analytical standards and reference materials, need for continuous training, and the pressure to get the results out very, very quickly. You mentioned something, Cheryl, that actually was mentioned, it just hit me. It was also mentioned by, I think, Dylan from Guyana, where he mentioned the challenge for toxicology and overdose, toxicology for overdose and poisoning cases, where they have limited access to patient information. So there seems to be a disconnect between the laboratory and, let's say, the emergency rooms, where I think, as you mentioned, someone may present to the emergency room with an overdose or poisoning case, and they're not even aware that this person has taken an NPS. I was actually in an event yesterday with Brazil, and they mentioned the Brazil's early warning system, and they mentioned that one of their biggest challenges is interfacing with public health, the public health system, that there's a lot of information that can be garnered from emergency rooms and other services, but there seems to be a disconnect between the laboratories and those services. How do you think, and the other panelists can jump in here as well, how do you think you can bridge that gap between yourselves, the early warning system, and the emergency rooms and other parts of the public health system?
Okay, well, hold on one second. Right, what I can say here is this. The way in which we are actually going to approach this, and ironically, it just came out of when we were having a meeting with Minister, this has to be seeded from above. In other words, like for us in Barbados right now, we are dealing with the whole concept of Mission 2030. And the mission Mission Barbados has about 6 objectives. So we are in objective number 4, which is about public health and safety and crime. Okay. Now, what this means is that for us, we know what we require to be able to deliver the information to you. We also know what we require as input information from the other entities, like whether it be Queen Elizabeth Hospital, accident emergency, or whatever. The way that I am going to approach this is that I will be telling my minister what I need to have, why I need to do it, how it affects the whole criminal justice system, right? And if I can successfully do that with him, then basically I say to him, this is where you need to help me. You know, you need to represent for us with the Ministry of Health. In other words, when because yes, okay, the ministers are not necessarily supposed to be part of the day-to-day administration, but they're the ones that are pushing the policies. So what I'm saying to him is, you need to drive a policy now of cooperation and sharing of the information, okay? Which should be like at your level, the Minister of Health, Minister of Home Affairs, okay? If I can get that type of framework started, then literally they're the ones that will make the introduction, so that when I then approach the CEO of the hospital or the doctor in charge of accident and emergency, all right, then we will be able to see how we can go from there. One of the things that a lot of the doctors in accident and emergency are very wary of is that they are very hesitant and scared of any information that they are giving us having legal ramifications or implications. So we try to emphasize to them, look, we don't need to know who the patient is. We don't need to know their names. We don't need to have any of that information. We just need to be able, you can keep all of that information. To us, they're going to be a number. You're the one that keeps the nexus as far as the connection between knowing what that number is connected to within your records. We just need the data, okay?
Right.
So that then we'll be able to create the profiles for what we're seeing, and then we'll be able to know how best we can utilize that information and create, there'll be programs or whatever to be able to inform the public and put that additional net for the security of the country. Because I think once we all recognize that the EWS system is not just about law enforcement, that it leans more towards public health and safety than towards criminal activities.
Right.
Once everyone understands that, and the ministers understand that, and they understand the tie-in and all the segues, then I am certain that he will be able to be a champion for us. So if I
Right.
could get it to work, I'll let you know.
Okay. I think also in addition to approaching it from a policy perspective, I think also, and I know some countries on the panel have done this already, is also including the on your early warning system in the group of agencies, your stakeholders, having representation from ministries of health and from emergency rooms specifically. I think once you can foment and build those relationships, then slowly you'll be able to get a lot more cooperation. Another thing coming out of the meeting from yesterday that I attended in Brazil, very, very interesting meeting. So Brazil relaunched their early warning system a couple of years ago. Actually, 1 year ago. It was in an experimental phase, and then they officially relaunched it last year. And yesterday, they actually launched a platform, a technological platform for information sharing across their early warning system. So in terms of detection, if the police detect something, there's a platform they can enter to upload standardized information to the EWS. If it's detected in a treatment center, emergency room, etc., it's the same thing. So that's something that we will tap from the Brazilians to see how applicable it is to your jurisdictions. I think it's a good idea, but it's something we need to work towards. But I think also fomenting and strengthening those relationships with the emergency rooms will help. So just a couple comments. I want to respect your time. I know you all are very busy people. Let me get to a couple of the comments that I see here. Mr. Kurt Richards from the early warning system in Guyana, very graciously shared some comments on strengthening regional collaboration. He said that from a Caribbean standpoint, strengthening collaboration between forensic labs is critical. Cheryl, you mentioned this in your I think you had it was actually not on your slide, but it's something you said that you want to do. You want to re-engage. I made a note of it. You want to re-engage with all the labs once you are up and running. You're fully up and running. And I want to say, even though the lab in Barbados, I'm aware, faced some challenges and wasn't fully operational, the fact that you were still able to assist the early warning system there in issuing 3 very important alerts, I think is commendable. So I look forward to seeing what can happen when you're up and fully running. And I want to say to you as well that when you send your results to the EWS in Barbados and the EWS shares it with us, we share it with all of the countries in the hemisphere, all of our member states. We have a platform, it's called SATA. So you can go on SATA and you can pull down every alert from every country that has shared it from us. So the regional cooperation is already starting from a sharing information perspective, but from the perspective of the labs, I think it would be great to see a lot more collaboration happening as well. So continuing with what Kurt said, strengthening collaboration between forensic labs is critical. Enhancing their ability to share information quickly can significantly enhance national and regional responses. I think the establishment of a secure platform that allows labs to share analytical data, this mirrors exactly what you said as well, Shara, and spectral information and identification in real time would directly support and strengthen EWS and aid countries with lesser equipment and resources. One of our biggest challenges is how can we get countries with greater analytical capacity to support those with less. So that's a big thing we at CCAT are thinking about. Kurt also mentioned harmonizing analytical standards and reporting formats, and I completely agree with everything he said. And he also shared with us a report that they did. It's in the link, it's in the chat if you're interested. I will ask Kurt to also share a copy that we can email to you if you want. But they did an analysis of seed substances with the lab in Guyana. We also shared in the alert, in the chat, the alert that Cheryl was referring to about, I think this is the one with semi-synthetic cannabinoids. So that is shared in the chat as well. Let's see. Right, and Paola just shared the link to the SATA webpage in the chat as well, if you're interested. And then finally, very good question from Elizabeth. Have there been any deaths in the region related to, I assume you mean synthetic drugs, Elizabeth, so I'm going to ask it that way. So the panelists can think about that, and we will end with that. But first, Dr. Ronald Chase from Barbados stated, I have enjoyed these meetings. I would like to highlight our colleague from Trinidad regarding the detection of LSD from 2 biological samples, but there were no seizures of LSD in Trinidad. I think this highlights the importance of having the facility for labs in this region to test biological samples for NPS and protocols in place for biological samples to be taken when persons present to the emergency centers and medical health centers. Again, there seems to be a disconnect between the early warning systems and the medical facility. So that's something we need to look into a little bit more. The EWS is an asset to the public from a criminal justice perspective and equally important from a health perspective. I totally agree with you, Dr. Chase. And he also adds the biological samples can be sent under a confidential code similar to the system that is currently used for HIV testing. So that's something that we need to think a little bit some more. So I will leave the last question to Ms. Japal from Grenada. So is there any data related to deaths in the region related to synthetic drugs? And I will give the floor to the panelists to answer this question and also provide any other final comments that they want to provide. Let's start with Delon. You go first.
We haven't been gathering data on such, but it's something that we do look forward to do in the future with the collaboration that we envision having in the future, because such information would be very important with regards to supporting the early warning systems.
Okay, thank you very much, Delon. Lakeisha?
I'm currently not aware that we have any deaths related to NPSs.
I will, okay. All right. I'll leave it at that, Lakeisha. Thank you. Tracy Ann?
I am also unaware of any deaths related to NPS. Usually when someone dies, if we have found fentanyl in cases, but it's not clear as to whether or not the death is as a result of fentanyl or otherwise. So we're not sure.
Okay, thank you very much. Michelle?
Why is it always Trinidad that has to provide the data? We have been doing it a little longer than you all. So we do have one case for many years ago where they found a foreigner dead in a hotel and he was injecting himself with ketamine. That's many years ago. So before we had early warning system. But in Trinidad, it's very visible in social media and on different platforms that persons are using the drugs and that they're collapsed on the ground after parties and they're being stretchered off by ambulances to the hospitals and so on. And it puts up pressure on the politicians to respond to this crisis of seeing persons collapse on the ground after FEDs. What I can tell you is that the Accident and Emergency in Trinidad, the Ministry of Health doesn't have the capacity to test for these cases that are coming in. We would sensitize and tell them, okay, we're seeing ecstasies, we're seeing ecstasy or methamphetamines, we're seeing ketamine and so on, but they do not have the capacity to test. So all they will do is go with anecdotal data that the person might still be conscious to tell them, or they will treat the symptoms, or they will just leave them in a hospital bed and let them recover. But there's no testing to say what drug the person has presented in. For the first time last week, however, someone died in a party, and the pathologist could not say what had caused his death. There was a left ventricular failure, etc. But there was no alcohol present in his system that of any note, like 42 milligrams per deciliter of alcohol. There was no blood clot that could explain his heart failing. There was no blocked artery that can explain it. So the pathologist at autopsy said pending toxicology for the first time. And that case came to us at this Forensic Science Center because of the pending toxicology investigation, but also because it's a sudden and suspicious death. That's what qualified it as a forensic toxicology case. As well, the law enforcement did not give the approval for the family to bury or cremate the body until the toxicology results were in. So long story short is I actually did a case. I did this case, we found ecstasy in his system. This was relayed to the pathologist, and the pathologist now basically said he now has an explanation as to why there was a left ventricular failure, and he put it on the medical cause of death certificate. So the cause of death in this case has been ruled as left ventricular failure pursuant to the presence of ecstasy, methylene dioxymethamphetamine in his sample. This would be our first death directly linked to a synthetic drug in our population. So that was shared with our early warning system colleagues yesterday in a meeting, and they're currently crafting the alert that is going to be issued, getting all the information from the Ministry of Health. We try not to link the information to a person so that it cannot be identified. So they're a little bit general enough to say, members of the public are advised about the harmful use of these synthetic drugs, which are linked to deaths. We won't try to pinpoint that we're actually talking about a specific case.
Thank you very much, Michelle, for that. Very, very, very interesting, timely. And I think, I think Cheryl responded to the question in the chat where she said she doesn't think that there've been any deaths, but having toxicology results going forward will be helpful.
Yeah. But I think most.
I wanted to add to the comment that I had placed in the chat. Sorry. In 2017, we had a situation. It was a suicide where, and we knew it was ketamine because the lady had the IV with the bag and the needle in her arm, and so we knew it was suicide and it was ketamine. But the thing was that was so early. That was in 2017, so we would not have been part of an early warning system as that. But I understand the challenge with the toxicology, and that is one of the things that we want to be able to put in place going forward, especially to set up a system whereby even if our toxicologists are on call, because obviously when these people are coming into accident emergency, it's not necessarily an 8 to 4 situation, okay? And what it also means is that the persons in accident emergency also need to be guided as to the protocols as to how they best to capture the samples, which tubes to put them in and various things like that. And then how they're supposed to either be secured there and then be communicated to the Forensic Sciences Center. So we have a lot of groundwork that we have to do with the other agencies to be able to set up systems, because at the end of the day, our investigations are only as good as the exhibits that are being submitted to us. Okay, so we don't have the control for when they're collecting the specimens, but we know that we need to inform them as much as possible as to the right way to do it, so that we can have a little bit more confidence that when they submit, that the result we get is really a true indication of what may have transpired with the person.
Understood. Thank you very much, Cheryl. Delon, you
Yes,
wanted
and
to add something else?
just to add, I think in most of the situation, due to that disconnect I alluded to in my presentation, whereby there's a disconnect with the medical facility and the forensics. And a lot of pathologists would just report heart failure or cardiac arrest, but you're not sure what caused it, or the underlying factors that may lead to that. And I think once we form that framework, set up that framework, then I think we will be able to we'll be in a better position actually to recognize what are some of the underlying factors or causes of these cardiac arrests or heart failures resulting from the use of these psychotropic substances, psychoactive substances. So it's not that it's not a matter of the non-existence of the substances, but being able to detect the presence in individual who present to the health facility under circumstances, and be able to detect it early and present that data so that it can be public awareness in that regard.
Thank you for that, Delon. I mean, I'll stick my neck out here and tell you, I know that there have been deaths in more than one country in our region, in the Caribbean region, confirmed. But thankfully, they remain very, very low. We don't have any, fentanyl crisis as was experienced here where I live in the USA, and thankfully that will stay just like that. But there have been deaths in at least a couple of countries, and I suspect that we are severely undercounting and in many cases unaware of what is happening because of that identified disconnect. It was mentioned yesterday very strongly by Brazil, and I think a number of you, Guyana, Jamaica mentioned it as well. Barbados mentioned it, that there is this disconnect between the medical fraternity and the toxicology and forensic labs. So that's clearly something that we need to think about some more and address. Okay, I think that we have spoken enough. We can say a lot more, I am sure. But I wanna from on behalf of CCAT, on behalf of the Inter-American Observatory on Drugs Unit, I want to first of all thank the panelists for your very insightful, informative, and in many cases, eye-opening presentations. We can see a lot of similarities among the countries in terms of the equipment you use and the methodologies you use for testing, for screening and for confirmations and the rest of it. There are clearly similarities in the laws. The vast majority of you do not need to provide information on, potency. You just need to identify the substance, and that's sufficient for prosecutorial purposes. But I think we need to go a lot further where potency is concerned. A number of challenges are very, very similar. Equipment, standards, libraries, etc. You all are in the same boat. where that is concerned. Some better than others, but you're all very much in the same boat. And then this issue with the disconnect between the medical facilities, particularly the emergency rooms. I want to single out the emergency room because when there's a crisis, this is where most people go. You may go to a clinic, you may go to some other facility, but most people are going to go to some type of emergency room, and we need to get them more closely involved in the early warning systems. I think there's a need for standardization. I think if we can standardize as much as possible, and it's impossible to completely standardize everything, but if we can all speak the same language, I think it would be fantastic for information and for reporting purposes. And let's see, pink cocaine was mentioned by Trinidad. I know there's pink cocaine in other countries as well. But I see where there are synergies and I see where there are opportunities for making things a little bit better. Cheryl, once you get settled, I will link with you and others here to see how we can get that conversation started about creating some sort of linkage among the labs in the region. I think that is critical going forward. Not only will it help you in your day-to-day work, but it will certainly help the early warning systems as well. So with that, I want to thank, let me make sure that I thank each of you very specifically. I want to thank Delon, Director of the Forensic Science Laboratory in Guyana. Thank you for your presentation and for your insightful comments. Tracy Ann Bennett, Director of the Chemistry Department of the Laboratory in Jamaica. Thank you, Tracy Ann, for your presentation and for your Lakeisha Cavalier from the Forensic Science Laboratory in St. Lucia. Very good presentation and insightful comments as well. Michelle Nasir, you shared some new information there with us this morning and this afternoon. So thank you for your presentation and for the detail that you presented as well. And Cheryl, finally, Ms. Cheryl Corbing from the Forensic Sciences Center in Barbados. Thank you for jumping out of your very important meeting with your minister and joining us at the back end of our webinar and for sharing some very good information with us as well. You are all very, very, very good, very, very helpful, very, very useful information. And I look forward to engaging with all of you again in the future. Before you all go, I would like all of you to please, if you look into the chat, you will see, let me see if I can open it here. I'm going to ask my colleague Paula. Paula, if you can present, if you can put the QR code on a page and just present. Yeah, just share your screen because it's not downloading from the chat.
Okay.
We would like all of the participants to please use your phones, use your cell phones, open your camera, take a photo of, well, not take a photo, point it at the QR code and fill out the evaluation form so that we can give us some feedback on this event and any other information you want to share with us. So again, thank you all, the participants, all of you for participating. I hope you found some benefit in this discussion, and we look forward to engaging you again in the future. There you go. There's the QR code. Please fill out the evaluation form before you go. And we look forward to engaging with you again very, very soon in the future. I found this discussion really enriching, hearing the different perspectives, seeing the similarities, and also seeing the unique bits of what's happening in the countries here. So we need to have more of these discussions and to elevate it as well to the policymakers so they understand what's happening. So with that, I will ask Paula to keep the screen up just for a short while, and you can fill out the evaluation. And I hope you all have a fantastic rest of the day, and we'll see you soon in a future event. Thank you all very much. And again, thanks to my colleague Paula for supporting this event as well. Have a good day.
Thank you, everybody, and have a good afternoon.
Thank you.
Thank you, and have a blessed afternoon.
Thank you, everyone, and nice to see the faces once again. We must stay in touch. Bye.